What I'm going to do, as Fran has summarised, is really give you a walkthrough of the complaints regulations, because we find many dental practices aren't even aware of the fact that there is any complaints regulations. So if you're involved in complaints handling in your practice or whatever your role might be, hopefully it will be something that you can look through in terms of looking at your own policy to make sure that you're the right side of the law. And then I'll try to give you some hints and tips for some practical things that you can do with your handling to make you feel more confident with it. I hope that all sounds okay. So hopefully you can see the title slide at the moment. So if I could go to the next slide, please. So I think I've covered that off in terms of describing what I'm aiming to do for you today. So let's go to the next slide. So this is a little background for you, just to let you know what it looks like from a heat point of view within NHS England's team at the moment. So we have a customer contact centre who handle all of our inquiries that come through the door, be it complaints, concerns, feedback, question about the vaccination programme, whatever it might be. And this is a classification of inquiry that they take called general inquiry. It's usually an anonymous call or a one-time fix that somebody might come through our contact centre, usually asking to locate a dentist, basically. And what you will see from these numbers is that in a normal month, we would get somewhere in the region of about 1,500 people coming to our contact centre asking us to help them find a dentist. And then you can see at the onset of the pandemic, those numbers disappeared almost altogether because nobody wanted to go to the dentist. And so we dropped down to about 200 or so. And then those numbers started to creep up before they pretty much then exploded. And you will see the numbers more recently are up towards 5,000 people making contact every month. To put this into context for you, last month was the first time in NHS England's history that we had more contacts about dentistry than any other type of contact. 55% of our overall contact was people trying to locate a dentist, basically. So I thought that'd just be helpful for you to be aware of the volume of traffic that we're getting coming through on this subject matter. And it might also explain some of the frustration that you might face in terms of people phoning your practice who have been all over the place trying to find somewhere to call home, I guess. Next slide, please. We've got a slow graduation of the slide coming in now. Effects I didn't even know that I had. Isn't that great for a Saturday morning? So just what I want to do as well is to try to put across to you that what complaints handling about is in the NHS, and certainly part of this presentation is do it once and do it well. There are lots of different asks from different bodies that might come at you around complaints handling, and one of your own complaints might end up in a number of different organisations, but all arrows actually point the same way. There aren't any contradictions, and everyone that you'll interact with actually wants the same thing, just perhaps worded slightly differently. So if we kick off with the GDC in terms of what they ask for from you, it's to have a clear and effective complaints procedure, which seems pretty reasonable. Next slide, please. Hasn't moved for me. I don't know if it's moved for you.
I've got the slide on here with the 3 green boxes.
Yeah, it's moved now. Thank you. It's moved. Thanks. So just to unpick that a little further, the GDC gave a little more context for what they're actually talking about. So to make sure that you have an effective complaints procedure and that it's readily available, that's key terminology for you. It shouldn't be something that patients have to hunt for or ask for. They shouldn't have to ask a receptionist for it. It should be easily displayed, so it's something that's easy for them to access. You must respect patients' right to complain. This is also an important one. Somebody bringing a complaint doesn't mean that there's a reason that you shouldn't see them anymore. It's something that patients do worry about, and I'll give you a hint and tip around how you can address that at your acknowledgement stage. There's lots of research that shows patients are far more nervous about complaining in primary care, including dentistry, than in secondary care. Might not feel like that to you, certainly at the moment, but there's lots to suggest they're far more fearful of reprisal in terms of actually complaining in a primary care setting. Finally, what the GDC says is that you must give patients who complain a prompt and constructive response. We would never disagree with that, but don't be too misled by prompt. What's far more important is that you do it once and do it well, and investigate properly, take the time that you need and issue one response rather than being in a position where you're ping-ponging back and forth with the
Sorry, Ray, can you please just switch your mics off, please, so that you don't interrupt the speakers? Thank you.
Thanks, Fiona. Next slide, please.
Oh, sorry, there's a piece on the end of that.
Oh, sorry, thank you. Yeah, so that's just what, do you want to go back and I can just cover that off? So there is no regulation around private complaints, just to be clear, but what the GDC actually quite helpfully says that it makes good sense to actually have one procedure that covers both. So whatever your standards are around NHS complaints handling, adopt the same processes in your private practice. There's a slight subtle difference in terms of where a complainant can go if they're unhappy. So in NHS treatment, as I'll talk about a bit later on, they can go to the Ombudsman if they're unhappy with their complaint response they receive from you at the practice. With private complaints, they can't access the Ombudsman, but they would go to the dental complaint service. Thanks, Fiona. Next slide, please. So the bulk of what I'm going to talk to you about for the next 10 or 15 minutes are the complaints regulations, which were published in this form back in 2009. And this is what we find lots of practices aren't actually familiar with, which means that they're in danger from a policy point of view of actually not meeting their legal requirements around their complaints handling. So if I was in a room with you today, I'd be asking you to show your hands in terms of how many practices have a complaints policy. And then I'd follow that by asking you how many people have a reference to these regs in their policy. And again, usually when we're in a room with people, most people stick their hand up to say yes to a policy, but most then get a bit shaky and eventually come down when they realise they don't actually reference these regulations. So that's the front page. That's what they actually look like. Snappy looking document. 20 so pages of legal jargon, pretty much. But we're going to walk you through that this morning and try to give you some hints and tips to make it usable for you back in practice. Next slide, please, Fiona. So something to give you a kind of an early tip around things that we see practices stumble with. If an issue is raised orally with you within the practice and you can resolve it within 24 hours, you don't have to actually log it, record it, document it as a formal complaint. So that's usually what we call a first time fix, something where you almost know the answer to the question as it's being put to you. If the person's happy that you can get back to them within that time frame, you don't have to log it as a complaint. The flip of that is if someone brings you an oral complaint in the practice and you can't actually resolve it within 24 hours, then you actually have a responsibility to write that up as a statement, give it to the complainant, get them to sign it, and it becomes a written complaint as if they'd actually written it themselves. So the thing you have to really look out for in practice is hearing any of your staff saying, you must put that in writing. That is not within the regulation. You can use phrasing such as, are you able to, would you like to put it in writing, but you cannot say must. A patient has to be able to put something in as a complaint verbally if that's what they want to do. Sometimes it's very difficult to understand what is the thing in front of me. Is it a complaint? Is it a concern? Is it just feedback? And what we would say is never be afraid to ask. People are quite taken aback if you say, can I just check, is this a complaint or are you just giving me feedback? And often they will say, oh, I don't know, what's the difference? So that's your opportunity to actually sell them feedback and actually say, look, we do lots with feedback that we get at this practice. We learn from it. We do, you said, we did, we share with you what we've actually done as a result of feedback. So you don't actually need to make a complaint for us to take action on something that you've told us. And for many patients, they will accept that. There will, of course, be those that will say, yes, that's all well and good, but no, I still want to make a complaint. But just get your staff familiar with rehearsing almost and practicing that discussion around, is this a complaint or is it just feedback? And work that through with the individual. Often that will be based on how much they trust you, what they know of you, and what their relationship is like with you already. Next slide, please. So as far as timeframes, it might come as a shock to you to know there is only one really specified timeframe in the complaints regs, and that's at the acknowledgement stage. So you have 3 working days to acknowledge a formal complaint. So that's a non-movable feast. If you're the person in the practice that is involved in leading on complaints handling and you're on leave, that 3 working day clock cannot stop. It has to be continued by somebody else in your absence. The regulations also go as far as telling you what you must include at the acknowledgement stage. So it's not just a one-liner. One of the things you specifically have to offer is a discussion around how you'll handle the complaint. So some practices pick up the phone and speak to every complainant on receipt of a complaint, which is good practice. You can do that if you want, but you don't actually have to. You just have to make the offer via your acknowledgement. So you'd include a line in your acknowledgement letter to the effect of, if you would like to talk to me about the way I propose to handle your complaint, please let me know. Many patients won't take you up on the offer, but it's something that you have to make. We still see a lot of practices that have 10 working days in their policy as their response time frame. So not the acknowledgement, but the response time frame. The good news is you don't have to have that anymore. And 10 days is really, really short. So what you're meant to do now, according to the 2009 regs, is actually negotiate a timeframe with a complainant based on the complexity of their case. So you'd look at the complaint when it came in. It might be something about 3 months worth of treatment, lots of different clinicians involved, and that's not a 10-day job. So what you'd say to the complainant is, if you would like to, I've looked at your complaint and I'm going to aim to respond within 25 working days. Is that okay? It's meant to feel like a negotiation rather than something that you've imposed. So always include the "is that okay" bit at the end of the sentence based on whatever it is you think is the time frame that you can manage the complaint. A simple tip: I would under promise and over deliver. So if you look at it and you think you can probably do it in 20 days, say 25 would be what I would suggest. A complaint should be made within 12 months of an event or of knowing that someone had cause to complain. So if somebody comes forward about something that happened in 1986 and says they want to complain about it, they can't. The regs are here to protect you from that. The loophole there is knowing you had cause to complain. So that might happen in dentistry where a patient has been with you for a number of years, seems quite happy with what you've done. Then they move house, go to a new dentist. New dentist sits down with them and says, "Oh my goodness, who was your previous dentist? What have they done to you?" That 12-month clock would start at the point that that new dentist imparted that information to them. So that's just something to look out for. Whilst the regulations do not stipulate a KPI as such, so 10 working days isn't there anymore. So again, if you've got that in your practice policy, it's something you might want to look at. You can be more generous with yourselves if you want to set a general KPI. But again, the emphasis here is on setting one on a case-by-case basis with each complainant. But there is a worst case scenario. So this is not meant to be a benchmark. This is meant to be an absolute limit, and that's 6 months. So if a complainant hasn't had a response by 6 months from a practice, they can actually technically fast track and go straight to the second and final stage of the process, which is the Parliamentary and Health Service Ombudsman. Now, what happens when that happens is the Ombudsman will be unlikely to want to take the case because they actually haven't got much to go on. So they will likely contact you at the practice and give you a hurry up. And they will also likely come to NHS England and ask us to issue a breach notice to you as a practice for failing to comply with the regs. It's quite unusual, but it can happen. What I would do is I'd give you a tip here is if you get towards 6 months and you haven't been able to respond, give the complainant some choices. So basically what I would say is give them the option of saying, look, we can wait for the person to come back. So let's say the reason it's taken so long is someone's on sick or on maternity leave. Give them the option of waiting, or alternatively say to them, we can complete the response, but we're going to need another dentist to review your notes, and it will be a records review response that won't have involved the person that you actually complained about. So you can always present that option. If you do that, be really clear when you write the response that that's what you've actually done. Next slide, please. Just to very quickly cover this one, because it's not as much of an issue in dentistry as in other parts of the NHS, but perhaps is more relevant during the pandemic. If you get a complaint come into the practice that's about something that's happened at the dental practice, but the complaint also mentions another part of the system, such as secondary care or the GP, for example, you can't just reply to your part in isolation. There is now a duty to cooperate and coordinate across multi-agency complaints. So what that means is one of the bodies complained about has to actually coordinate on behalf of all of the others. And I would suggest getting in really early with your complainant if they've chosen you, yet the part of the complaint that is about you is really, really small. So sometimes the complaint will come in, there's a tiny bit about the practice and then a walloping great section about secondary care. Actually, you really need to encourage the patient to see that it would be much better coordinated by the hospital. You'll provide your response to the hospital and they'll coordinate from there. And if the patient agrees with that, that's the situation you want to find yourself in. Unfortunately, the regulations would say that if the complainant is adamant that it's you that's going to lead, then your responsibility would actually be to gather the responses from the other bodies involved. Next slide, please, Fiona. We often see practices falling foul of this one. So a complaint can be made to either the provider or commissioner of the service, but not to both. So the way you would represent this is in your leaflets and promotional materials in the practice, you would say, if you want to make a complaint about your dental care, you can complain to us at the practice or to NHS England. That's their choice. When you then come to write your response, what you would say is, if you're unhappy with the complaint response we've provided you with, you can either come back to us practice, or you can escalate to the Parliamentary and Health Service Ombudsman. They are the only two choices. We do sometimes see practices say, if you're unhappy with our response, you can go to NHS England. That's not true. They can't. We are not the second bite of the cherry. They have to choose us at the beginning instead of actually coming to you. That's their option. In keeping with what the GDC says, I said earlier, there's lots of consistency in the different asks. The regulations say you have to have a well-publicised complaints process and that needs to reflect your complaints policy. Something to quickly mention to you, this is a complicated one, so I can't get into huge detail with you, but it's just to highlight the role of the responsible person. If you make a complaint to a hospital, you don't get a response from the consultant or the ward manager. You get the response from the chief exec, and it's the corporate view of the hospital. The same should be applied in dentistry. Your senior responsible person, who's usually the practice owner, senior partner, etc., should be seeing and signing off every complaint response that your practice makes because they are legally accountable for them. It's about not marking your own homework as far as the patient is concerned. So if I had an altercation with a checkout person at Tesco, and I made a complaint to Tesco, I'd be a bit taken aback if I got a response from the checkout person at Tesco. That wouldn't suggest that Tesco had taken my complaint very seriously. And the same should apply here. So it's just worth checking when you're, if you're leading on complaints or involved in complaints, your responsible person does need to be involved in the sign-off stage of the process. There's two elements of reporting that are referenced in the regulations. So a practice should make an annual report on complaints available to the commissioning body upon request is what it says. That's not the KF41B data return that you do every year. In my 8 years here at NHS England, I have never seen a regional team ask a practice for an annual report because I don't actually think they know that they can, and I've never told them. So we'll keep that between ourselves. What you do have to do is your KF41B data return. That's the thing you do every year, which is a list of the complaints that you've had, what they were about, and that's actually nothing to do with NHS England, despite people thinking that it is. It's actually collected by the BSA and NHS Digital on behalf of the Department of Health. If you get a complaint come in that's about someone that's left the practice, unfortunately, you still have to investigate and respond. You can't simply say you can't do this because they're not here. So think about details that you've retained for people when they move on. Always useful to have information about who their defence body is. Try to locate them, keep an audit trail of what you've done to track them down. If you've been unable to find them, sometimes that does happen, you still have to try to respond to the complaint. And the same would apply as if you'd missed a complaint around the 6-month rule. You'll need to get another clinician in the practice to do a records review in order to respond to that complaint. Next slide, please. Next slide, please, Fiona. I'm going to skip past through this bit. And again, next one, please. And one more, if you would. Thank you. So we should, no, back one, sorry. I'm going too fast for you. So it should be the first slide on acknowledging complaints. Super, that's the one. So I'm just going to give you a few hints and tips for what a good acknowledgement letter should actually look like. So think of it as first impressions, and these are things that you can turn into a template letter if you want to, but obviously the importance is to not make it look like a template letter. When a patient makes a complaint in dentistry, they actually have a number of options available to them. They could have really, in terms of if they wanted to go to the CQC, it's not part of the complaints regs, but it's something they could do if they wanted to, which will bump you to the top of the list for inspection. They could go to the GDC if it's about one of your registrants, which is again, not part of the NHS complaints regs, but if that's the option they want to take and think that it might be about fitness to practice, although it's probably not, that's where they might go. Your registrants don't want that. They could be a keyboard warrior and decide to go public on social media in a way that's very difficult for you to actually respond and have your side of the story represented. You don't want that. So actually, the fact they brought the complaint to you, I know gratitude is the last feeling you'll have when you open a new complaint, but you are actually grateful because they've given you the power. They've given you control of the narrative and put you in charge by coming to you. So it's a huge stress buster to them if you open an acknowledgement letter with a thank you. So thank you for taking the time to complain. I'm really sorry that you've needed to complain, but I'm really pleased that you've told me about it because you've given me a chance to respond. That's a bit of what we call sad but glad, and you can use that a lot in your written communication with patients. It works a treat. You would address consent issues. There's absolutely no time to talk through all the different consent scenarios you might face yourself with, but what I would suggest is have a standard consent process. If the person bringing the complaint is not the patient, send a consent form out to the complainant, ask them to get that signed by the patient and return to you. If in any doubt about a consent issue, always seek advice from your defence body. They'll be used to walking that through with you. Back to what I mentioned in the regs previously, you have to make that offer to discuss the handling of the complaint in the acknowledgement letter. So that line that says, if you would like to talk to me about the way I propose to investigate your complaint, let me know. Clarifying the complaint then makes this look like it's not a template letter, even though it is. So when you've read the letter of complaint and you think you know what it's about, you'd insert a couple of bullet points into the acknowledgement letter that would say, I've read your letter of complaint, and if I've understood it correctly, what I think the main issues of concern are, and then list 2 or 3. It says to the patient, oh, okay, they've actually read it and they have a plan and actually have understood what my issues are, even as early as the acknowledgement stage. This is about getting the patient on your side. The more you can do that at the beginning from the acknowledgement stage, you give yourself a much better shot of ending up with resolution at the end, even if the response that you put out basically says we didn't do a whole lot wrong. So it's about getting the patient back on side from the beginning. So you would explain the time frame for responding, whatever you think that's going to be based on how complex this case is. You'll let them know that you will contact them proactively if it's going to take a bit longer. That's also important to them. You're going to tell them who's going to investigate and how. This is really important to them as well. So let's say the complaint is that they've had a huge row with the practice manager in the middle of reception. What they don't want you to tell them at this stage is, and your complaint will be investigated by the practice manager. You'll have lost them from the get-go. So tell them the things that you're going to do. It could be, we're going to look at your clinical records. We're going to talk to the staff that you saw. If it was about something that happened on the phone, if you've got a call recording, we'll listen back to those call recordings. It says to them, this practice knows what they're doing. They're in control. They have a plan and they've taken me seriously. And then you tell them who they can contact at any time they want to while the process is running. Next slide, please. Just a tip, really, if the complaint has been made verbally, you don't really have any idea of the literacy of the complainant if that's the case. So it's maybe worth having a discussion with those complainants about how they'd like their outcome shared at the end. They might not actually be able to read the response that you've put forward to them at that point. Address any care or appointment issues right at the beginning. Don't suspend normal practice because someone's complained. Don't wait until the end to actually do what you need to do. Get on and actually address those issues from the beginning. Something that will massively impress the CQC is if you include a line at the end of your acknowledgement letter that says your care will not be compromised because you've complained. This is what patients are most worried about, and it reflects back on that line in the GDC standard about people should not be disadvantaged because they've complained. Next slide, please, Fiona. So very quickly now, I'll walk you through the process that you could consider for what you do after you've put your acknowledgement letter out. So you've won the complainant over with a good acknowledgement. What's going to go on behind the scenes? So you're actually going to make a plan for how you're going to investigate the complaint. So old school, but grab a highlighter pen and go over the letter and highlight every sentence that is making a point, and don't cherry pick. Don't think, oh, that's a bit of an awkward one, I don't really want to answer that, and ignore that one. Highlight every point that needs to be answered. And next to those highlighted sentences, put initials next to it in terms of who you need to talk to within the practice to get an answer to that question. Consider the use of statements very carefully. And the reason I flag this as something to be cautious about is when you create a complaint file, it's disclosable. If the patient decides at a later date they want to know everything within their complaint file, they can request access to it. If the case goes to the Ombudsman is entitled to the entire complaint file. Similar with the GDC, and very similar if the CQC come in and inspect, they're allowed to look through an entire file, not just the business end of things, not just the response. They can see everything that got you to that point. So sometimes if you give a member of staff a blank page and say, tell me what you remember about this, let's say it's a pretty disgruntled member of staff that's not terribly happy at the practice anyway. They really are not a fan of this particular patient. They could and do say anything. If they give you that statement and you place it in the file, you're then in a bit of bother in terms of the fact it's disclosable. So just think about whether it's a better use of time at the beginning to sit down with the person, take the statement from them, only write down the bits that are actually relevant to the complaint and the bits that you need to answer. Let them have their rant, but don't write the rant down, is what I would say. Then give them the statement and get them to sign that. Always refer to the clinical records, a really important one. We do see a number of practices who try to reply without actually looking at the notes and try to do it from memory. That never ends well. Try, if you're the person leading the investigation as well, to lose any assumptions that you have. And that works in two ways. So let's say the complaint comes in and it's about Nellie on reception, and she's nicknamed Nippy Nellie. And there's a reason she's nicknamed Nippy Nellie, because everyone knows she's a bit clippy with patients. If she's referenced in a negative way, it doesn't actually mean that she was negative on that particular day. It might be the patient that's very much the issue. The reverse of that could also be true. So you get a complaint comes in that's about positive Paul, who's always lovely on reception, and you couldn't possibly believe he'd ever say anything out of turn to a patient. Doesn't mean he didn't have a bad day. So try to start from a blank page and gather the facts rather than letting your own bias influence your investigation. If you get halfway through an investigation or even towards the end and you reach that point where you just think, I just don't know what it is that I'm doing here. I don't know what the point is. I don't know what they're looking for. It's never too late to go back to the complainant and say, can you just walk me through this again? Next slide, please, Fiona. Think about, so we're moving very quickly into the issue of responding. What does a good response letter look like? And just some hints and tips for how you can actually structure it. If you think about trying to lay it out in such a way where you're describing what happened versus what should have happened, and your response should bridge the gap. Another way to help you give a good tone to the response that you're writing is, our instinct when we write a response is to be defensive, to defend our position. But if you start from a point of what is the patient right about, and it's very unusual for them to be wrong about absolutely everything, there's usually something in there that they're right about. If you start from that position, it will change the flow and the tone of the response and make the individual far more likely to accept the bits that you tell them that they are not so right about. So always provide a summary of the complaint and investigation at the start. Think of it as doing your maths exam, where you are always encouraged to show your workings out. Show how you got to the findings that you're making when actually writing the response. So go again through, we've reviewed your notes, we've gathered statements, I've spoken to the staff, whatever it might be. Walk them through that as best you can and provide a chronology of what happened. Sometimes it's better to let the facts speak for themselves. Rather than actually saying, you said this happened and it didn't, just describe the chronology of actually what did happen, rather than having to counter with a negative piece of language in the way that you write the response. Think about the way you're going to apologize, if you're going to apologize, and make it genuine. My least favorite things in complaints ever are I'm sorry ifs and I'm sorry buts, because they actually aren't apologies. I'm sorry if you feel, I'm sorry if you are upset. Basically are saying, we don't think you were, we don't really believe your story, and actually we're not very sorry at all. And patients see through it really, really clearly. No apology is better than a false one, is what I would say. Consider any remedy that you can make as part of your response. And most importantly, consider the learning for the practice. All eyes point to learning as far as good compliance handling is concerned. Even if it's something really, really small, tell the patient what it is that you've done, not just for them, but in terms of making things better for everybody else. And importantly, at the end of the letter, you do have to signpost to the Ombudsman. So make sure in any response that you write, you're always outlining the details for the Parliamentary and Health Service Ombudsman. Next slide, please. I think I'm getting the two hands. Is it 9:40, Fiona-ish? I shall keep going.
Nearly.
Yeah, no worries. So just a little bit around apologies that I thought it would be useful to throw in for you. So Frank Gardner is a BBC journalist that you might be familiar with, and he was injured out in the Middle East while working a few years ago, but he still works as a journalist and regularly flies in and out of Heathrow. He live tweeted when he was stuck on a plane due to the fact that on 2 flights coming back into the UK, his wheelchair was lost. So his tweet showed a picture of him sat stuck on the plane as the last person actually waiting to disembark. Next slide, please. His BBC colleague jumped on the very poor statement that Heathrow immediately put out in response. So you'll note what they said. We apologise unreservedly if the service Mr. Gardner received today, etc. And then Robert Peston pointed out, why is there an if in this sentence? There was clearly a picture of Frank stuck on a plane. The if means this really isn't an apology at all. So it's just a natural language pattern to be aware of. Have a look at if you've used it before. Can't change it if you have, but try to be aware of it going forward in terms of your apology should be I'm sorry that's, not I'm sorry ifs, or none at all. Better than not have one at all if you genuinely haven't got anything to be sorry for. Next slide, please. The other one is but. So we never like to see a but after an if, because that means a walloping great excuse is coming. I'm really sorry, but means we're not really, and actually the excuse then negates the sorry that's come before it. So just another language pattern to be aware of. Next slide, please. So very quickly to walk you through what the CQC say about complaints handling. So it's absolutely guaranteed when your practice get inspected, complaints are going to be something that they look at. And the reason it's so important to them is that they consider complaints to be a proxy of your culture. So the CQC will deduce that if you're good at complaints handling, lots of other things will follow in a positive way as well. And the reverse would be true also. So if they are unhappy with your complaints handling, they will figure that there will be other governance issues that they need to look at as well. Next slide, please. And again, thanks, Fiona. So this is an excerpt from the Regulation 16, which is around complaints. And again, just to reassure you, the wording might look slightly different, but the CQC are actually asking you to do exactly the same thing as the GDC and exactly the same thing as the regulations. So just to emphasize the bottom there, the bit when I was talking about be careful about what lands in your complaint file, that's the statement to confirm that CQC can actually see all of the correspondence that you're holding on an individual case. Next slide, please. Really focus on your evidence of learning when it comes to your inspection. So what CQC will be wowed by is complaints a standing agenda item on your practice meetings? Even if you haven't had a complaint in between, have it on your agenda, use it as an opportunity to check that your promotional materials are up to date and are displayed in the practice, revisit an old complaint that might be closed, maybe do a kind of bit of role play around that whole, is it complaint, is it feedback, whatever you can do, document that in your minutes for your meeting. CQC do love this kind of written evidence. If staff have been on any training, also similarly fantastic to include that for them when they come in. What they will really be wowed by is that concept I mentioned earlier of you said, we did. So if you really are a practice that's learning from the feedback that you're gathering from patients, not just from complaints, but everything, tell it back to them via you said we did. You'll see this quite commonly in hospitals now where you said this is a problem, this is what we've done to fix it. It doesn't have to be big stuff. It doesn't have to be clinical stuff. It can be stuff that's really quite minor. It says to patients, I don't need to go anywhere else to take my issue. I can deal with this in-house. Next slide, please. So I'm just going to finish with a little bit of a chat about the Parliamentary and Health Service Ombudsman. So that's the second and final stage of the complaints process. They've articulated in a number of ways what good looks like. And this is my favourite of these. This is called My Expectations. And this was designed immediately after the mid-staffs inquiry that was called Hard Truths. And this is a complainant-led vision for what good looks like in terms of complaints handling. NHS England and PIC are actually designed a survey based on this. So some practices actually now survey complainants at the end of the process to get their views on what the complaints experience was like. And it's based on this. So that's something that you might want to consider. Not all practices do it, but some are thinking about whether it's something that they want to do. I'd quickly draw your attention to column 5, which is reflecting on the experience. Something that we think practices also might want to do is think about actually asking the person complained about in terms of what it was like for them. We often meet a number of clinicians out on the road who will say they've really been scarred by the complaints process. And it's rarely the complainant that's been the issue. It's the way they were treated within the practice. So after you close a complaint, give it a bit of space, give it a month. And if there was someone that was very specifically named that was the focal point of the complaint, sit down with them and firstly say, are you okay? And then secondly, say to them, what could we have done differently as a practice in the way that we managed the complaint, and just be open to what they might tell you. So it could well be that they felt that they weren't really involved, they didn't know what was happening, they didn't see the response before it went out, or they could say they felt really supported, really in control, that you really recognised how traumatic it was to them and that you kept them in the loop. But just be open to what it is they might tell you, because it's as important to learn from the person complained about as it is from the person that brought the complaint. Next slide, please. And again, please, Fiona, I'm just going to skip to the standards part. So just to highlight to you that the Ombudsman has published some new complaint standards in draft form that are presently being piloted across the NHS, including in some dental practices. What the Ombudsman is trying to do here is actually get a new legal superpower to actually give them a much greater authority around complaints handling and the quality of it. CQC have already said that they're going to sign up to these standards and will fold them into the key lines of inquiry when these are finalised in early 2023. So it's worth just having a look at them. My personal view is they could be a bit of a stretch for primary care and dentistry. They could perhaps be a little too focused on secondary care, but it's something that's likely to be coming all of our way. The other thing to mention to you is the forthcoming ICS bill, which will be coming on the 1st of April. There is an outside possibility that NHS England might not actually be handling complaints for all that much longer. So it might be a case of better the devil you know, because it could well be that it's an ICS that picks up the commissioning arm part of the complaints handling process. My hope is that won't be until 2023, but there is a possibility it could be as early as 2022, certainly at least for maybe the GP part of complaints handling. So just something else to have on your horizon to be aware of.